Hello, I'm Amirali Masoumi. I'm an interventional cardiologist and also advanced heart failure transplant and mechanical support specialist at the Columbia University Medical Center in New York. Welcome to CVI Heartbites. This session we will focus on cardiovascular diseases in the area of COVID-19, mostly acute coronary syndromes and COVID-19, with big question that where have all the heart attacks gone? I need to mention that CVI Heartbites is a free, non-accredited educational program produced by the Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by leading experts on timely topics in cardiovascular medicine. Due to the rapidly evolving and changing information around the COVID-19, this session is up to date as of June 9, 2020. I do not have any disclosures. And again, I need to emphasize that I'm going to share with you our experiences within the New York Presbyterian Columbia University, which was the epicenter of the COVID crisis. This by no means should replace the society recommendations or clinical judgment, as well as the hospital policies or guidelines. Today, I will try to cover a few objectives. One was the prevalence of ACS during the COVID-19 pandemic, ACS presentation, STEMIs or STEMI mimics, which to somehow dictated how our cath lab responded to the COVID-19 crisis, pathophysiology, and a little bit about pharmacology. And mostly we'll talk about some of the dilemmas that to this date exist around this disease. It is well known globally that the number of cardiac cases as well as ACS presentations declined during the pandemic. This is the data that initially came from the United Kingdom. It was similar within the Spain, who really suffered from the COVID-19 pandemic. They reported about 40% decline in their primary PCIs for ACS presentations, and more than 80% decline in the structural heart disease procedures. This was relevant within Italy, who really struggled with the disease as well. Then the data from on the left shows from Lombardy area, which was epicenter. It showed the significant decrease in STEMIs and STEMI presentations. Similarly, within Milan area, that showed more than 50% decline in primary PCIs. In the United States, we saw similar trends as well. 9 centers, high volume centers within the United States, reported about 38% reduction in their ACS presentations. And recently, this data from New England Journal of Medicine, a huge database from Northern California, which showed about 48% patient per week reduction in ACS presentations, both STEMIs and STEMIs. Because of the different time points that we entered this crisis, we had similar to the whole world, but at the same time, significant considerations in patients that they were under investigation, and also the ones that they were COVID positive. One big question to serve our patients better and also protect our staff and operators and healthcare providers was that how we can differentiate between the true ACS and also STEMI mimics. We know that COVID had different epiphenomena of presentations similar to STEMI or ACS, myocarditis, myopericarditis, stress-induced cardiomyopathies that could present like ACS. How we can treat these patients, and even if we treat them with primary PCI, would really change their outcomes or not. Also exposure implications, and how we can minimize the intubation by intubation or cath lab preparation and PPEs. The other dilemma was how we can achieve our conventional metrics, for example, door to balloon time. And what are the risks and benefits to coronary angiography with primary PCI and some of the older methods of treatment, like lytics, started resurfacing while we were going through the crisis. Initial data came from Italy, showed that when cath lab was very proactive, they took about 33 patients with COVID-19, but less than 40% of those patients had obstructive lesion that needed to be treated. At the same time, they noticed an increased number of healthcare providers and frontliners who got contaminated and were sick. So that put a pause, and everyone started thinking how we can do better. This is a middle-aged lady who presented to one of our sister hospitals within New York Presbyterian system with some underlying risk factors, very high risk features on the EKG, but when she went to the cath lab, she didn't have anything. And later on, she had a positive swab test. This is a data from 6 hospitals within New York system. They identified 18 patients with confirmed COVID. They took them to the cath lab. One presentation was very interesting. Only 33% of those patients presented with classic chest pain or angina. And the other interesting finding was that about 8 patients developed some sort of ST elevation during their hospitalization, which could be because of stress-induced cardiomyopathy or pericarditis, or the predominance of this disease, which nowadays we know more and more is the thromboembolic events. Regardless, 9 patients, about 50% of those patients went to the cath lab. 6 of them found to have obstructive disease, and 5 out of those 6 received treatment with PCI. No matter what, unfortunately, the total death was 13 patients, so mortality was more than 72%, and 4 of those IMI patients unfortunately passed as well. So how we can really differentiate true STEMIs from STEMI mimics? Emphasis on history and physical, but we all experience that a lot of these patients present in respiratory distress or intubated, so they cannot give us a very good history. On top of that, because of the restrictions, they were not presenting with their families, and we couldn't get collateral information, so that was very limiting as well. In terms of the EKG, again, it's essential, but we know that there are a lot of diseases that have some concerning EKG changes like aortic dissection, pericarditis, myopericarditis, cardiomyopathies, also electrolyte abnormalities, and more we noticed that the CVA catastrophes that could present with some high-risk features on EKG. But what we really cherished in our institution and found it extremely beneficial was point-of-care ultrasound or focus or limited bedside echocardiography. This is the data and document was published by Responsible Societies and JACC that essentially was a guideline how to prepare the cath labs, divide them to COVID and non-COVID labs, and to emphasize on the benefit of primary PCI as much as possible. To get the patients tested before the procedure was a routine. However, we know that the tests are not optimal. And for example, nasal swabs that are routine had only 60% positive predictive value. So at our institution, the emphasis was to treat all patients with full PPEs. This is the document and our pathways within Columbia system, which was published essentially with focus on serving our patients first and protecting the frontliners and operators and healthcare providers. We gauged our responses based on 3 time frames. Year 1 was during the crisis with PPE limitations and resource limitations because a lot of our staff been redeployed. Tier 2 was the contingency period, and Tier 3 that today that I'm talking to you, we're going through this tier, which is very rewarding, and we get some sort of normalcy and we can go back to our conventional therapies. Regardless, our emphasis and our priority was primary PCI, and to my knowledge, we never used any lytics within Columbia system. The reason that the lytic is not our best friend is that there is a paucity of data that showed that the lytics are beneficial when we administer them within 60 minutes. A lot of these patients had delayed presentations. We have data that patients rightfully avoided the healthcare encounters or emergency rooms. So most of those patients lost that window. Also, the notion that we can minimize exposure somehow is irrelevant, because a lot of these patients need to come back to the cath lab. So again, we will have re-exposure with those patients. And on top of that, we know that during COVID, patients may develop pericardial effusion, pericarditis, or cerebrovascular disorders. And using TPA will just add to the complications of this presentations. So in overall, we try to not to use lytics and put the primary emphasis on primary PCI. The other entity that we're experiencing these days are the notion of collateral damage. A lot of patients, as I mentioned, that try to avoid emergency rooms or hospitals. This is an example of a 68-year-old man with known for coronary disease, had some shortness of breath and dyspnea on exertion. He used some inhalers. Regardless, came to the hospital with TIA CVA presentation, which resolved. He had this EKG with already Q-waved and anterior septal. And when we did the lab work, his COVID was positive. He had high BNP and troponins. And unfortunately, this was his echocardiogram, which showed significant LV reduction, LV function reduction with wall motion abnormality. The other surrogate for this delayed or collateral damage was outside hospital cardiac arrest. This data is from Italy that showed more than 50% increase during the lockdown time period. The patient had more outside the hospital cardiac arrest. Within NYP system, we have similar trend that we submitted, and hopefully we will be able to publish and show you that later. The other issue that we dealt with was how to manage our patients in cardiogenic shock. Our routine protocols with emphasis on PA catheter and invasive hemodynamics, because of the risk of exposure, was very limited. Therefore, we tried to use surrogate hemodynamic criteria, for example, mixed venous or blood pressure and lactates. Regardless, we tried to divide these patients to 3 categories: AMI shock, acute decompensated heart failure, or cardiomyopathies. But what benefited us the most, knowing that this disease is a primary pulmonary and ARDS disease, if they had any elements of circulatory failure, we chose to go with and needed VV ECMO, we chose to go with VAV upfront, and relatively we had good success with that method in terms of overcoming the circulatory failure. This is another example that recently presented to our hospital, a 35-year-old gentleman with no real past medical history, no other personal or familiar past history as well, came in with intermittent chest pain. The periods that he had the chest pain, it was quite classic, but he reported that this been on and off for the past month or so. He initially had a febrile illness, which was diagnosed like an upper respiratory tract infection about a month ago, presented to an outside facility, got a chest x-ray. He was not hypoxemic. Presumably he had COVID, never got tested, but received a 5-day of azithromycin and inhaler. And after that, within 7 days, he really felt well and recovered back to his baseline. He presented with this chest pain presentation and some concerning EKG changes. Given his age and symptoms, decision was to take him to the cath lab. As you can see, unfortunately, he had a very heavy burden, thrombotic lesions all around his RCA. Given the fact that he still had a positive component. And also, he had chest pain, decided to do manual and then mechanical thrombectomy with the penumbra device with that result, as you can see in this angiogram. At this point, his swab was negative. This is the echo that showed an LV thrombus with significant LVEF reduction and wall motion abnormality. He then, given his age, we proceeded with a cardiac MR with viability, which showed severe hypokinesis of inferior and inferior septal wall, a late gadolinium enhancement, transmural infarction with significant microvascular obstruction. Also, he had an LV thrombus, which was significant, and we found it on echocardiogram as well. And also classic features of posterior medial papillary muscular infarction. At this point, his antibody came positive. So initially his swab was negative when we took him to the lab, but then later on, now his antibody is positive, and he's dealing with this scar of the disease. In terms of the pharmacology for this case, of course, aspirin, we used heparin. We loaded him with cangalor while he was on the table, and then we switched him to ticagrelor, and we used the glycoprotein 2B3A inhibitors while he was in the hospital and getting treated as per protocol. Regarding the unanswered questions and concerns, and if we are going to experience other surges or peaks, these are the elements that we need to think about. What are the measures and metrics that we can really live up to? For example, door to balloon pump, balloon time, and how we can overcome these, or how we need to modify those. What's the real pathophysiology of ACS and COVID-19? Because that will dictate how we can manage these patients during the presentation, and also for long time periods, especially if we don't use any stents. Do they benefit from vitamin K inhibitors or DOACs? What about Plavix or Brilinta in this population? And also for patients that their cardiac function, myocardium, won't recover, how we can treat and offer advanced therapies to these patients. What's the best modality, durable VAD or heart transplantation? And even if we consider these patients for these modalities, when we think these patients can tolerate the procedure and confidently we can clear them for advanced therapies. With that, I will stop here, and I will thank you for this opportunity and participating in this webinar. And if you have more information, or you need more information or questions, please contact me directly or through the CVI Philadelphia.org website, and you can follow them on Twitter as well. Thank you.